Thank you. Good morning, and thank you for inviting me here to present on behalf of the population health domain. I'm really pleased to see that Ian, Mark and Dave all seem to be honorary members of this domain. They all seem to want the same thing, so that's a really brilliant thing. So I guess one of the first things that I should say is that I think when we first started with the population health and implementation domain, everybody's questions was, what? What does that do? And I think it's fair to say that over the last 2 years, what we've been on is a real journey. And as I go out and talk to people around MAHSC, I think it's almost impossible to find people who don't believe that prevention and high quality care are the two real priorities for MAHSC. So it's brilliant to be in that space. I guess one of the things I'm going to try to do today is give you a sort of context. So where are we? What are we trying to accomplish? How might we do that? How might we support? But the first thing I wanted to start with was just this phrase that's at the top here of my presentation. And I genuinely believe that here in Manchester, we have an opportunity to do something really unique. So our future isn't just going to happen. Our future, we will imagine it in rooms like this. We will plan it in labs and in people's homes and in the organisations that we work in, and we will build it together. And I genuinely believe that the future is going to be different. So Dave's bubble, I'm a bit jealous actually that I didn't have that bubble slide, where we're reconfiguring those bubbles that say we've got a lot of energy and enthusiasm going into our healthcare provision. Let's begin to shift to we have equal amounts of energy and enthusiasm going into primary prevention and cure. So, what is population health? So for the purposes of our domain, we've had this working operational definition which we've popped into our business plan. So we're interested in measuring the outcomes of groups of individuals and changing the distribution of outcomes within those groups. And so when you start to think about that, you start to think about people that you might need to interact with. And of course, right at the centre of that are the citizens that we work with. But of course, with population health, you've got a rather large spectrum of new people to meet and to interact with. And in fact, you're going to hear later around programmes where really we're focusing on some of the social determinants of health. So poverty, so Aidan Halligan's doing a great piece of work here with the Well North programme. We work with practitioners in public health, so people whose primary roles are actually to prevent illness and to promote wellness. And of course that takes you into all kinds of different areas around immunisation, screening programmes, etc. But you can't work in population health without thinking about how you work with colleagues in primary care. And so for MAHSC, we've got a really good opportunity here. We've got Salford CCG, who lead on behalf of the Greater Manchester group of CCGs. And we actually have an opportunity to start to work to build conversations with primary care around population health and prevention. Now, within our domain, we've got a rather heady ambition, and that's to save 500 lives from cardiovascular disease by 2017. So the question is, how are we going to do that? And how have we arrived there with that ambition around cardiovascular disease? So one of the things we had to do right at the beginning was talk to all of our colleagues across MAHSC to try to work out what our priorities would be. And we landed on essentially 4 things. The first thing was that we wanted to prevent cardiovascular disease. The second thing was that we wanted healthcare, wherever it was provided, to be the safest it could possibly be. And the third thing was that we wanted high quality implementation and education and research. So I'm going to talk to you a little bit about one of the things that we've managed to focus in on, and that is our programme around health checks. But before I do that, I want to just show you this graph again, because you've seen graphs very similar to this. And you'll see that the good news is that our disease trends from heart disease and stroke are actually reducing. That's great news. But what you see here is the gap between Manchester and the rest of the country is not narrowing. So that's a major challenge. And you've seen these graphs before, but you'll see the nice dark blue belt across Manchester, which signals that the disease here is significantly higher in prevalence than elsewhere. So good news is Public Health England have a programme called the Health Checks Programme, and we have been running this programme now for over 18 months. What this means is that everybody between the ages of 40 and 70 without some kind of chronic disease are offered the opportunity to come in and have a screening test. So it sounds like a good idea, doesn't it? It sounds like for a population it would be a great idea. What's really interesting is that the uptake across Greater Manchester of health checks is as poor as 30% in some of the worst regions and only up to 60% in some of the best. So even though we're offering something which any other healthcare system would have a value attached to it, we're really, really struggling to get people to come along and take up this opportunity. And this is not because we've got a group of bad people. This is because some of the challenges that our communities face are really difficult to overcome. And so one of the things that we are trying to do in the population health domain is to try to think about how could we get people to access and uptake these tests in a much more reliable and systematic way. And you'll see here that there's an aim here to increase the uptake of health checks from 30% by 70% by December, and that's actually in one of our localities. That's in Salford, where we're working. And we know that to do that, we have to increase the staff's awareness, the patient's awareness. We have to work on call and recall systems. We have to look at how we can use laboratory testing better. And we have to think about how we not only find patients, but seek to treat them in a much more effective way. So whilst it might seem simple, actually when you dig under the surface of this, it's quite a complex piece of work. Our aim is to make that happen, and to make it happen not only in Salford where the pilot's happening, but across our conurbation in Greater Manchester in conjunction with the Academic Health Science Network. So that's part of a vignette around our population health programme. There's much, much more. But moving on to implementation, what can we describe to you here? So I'm going to give you a classic here. So 17 years. The gap between your ideas coming out of the laboratory and them actually reaching the patient. Not acceptable. So we know that the NIHR are really interested in how research can actually arrive at patients for patient benefit. And in fact, many of us have written grant applications where we've talked about our work very eloquently. And then we get to the bit about impact. So how are you going to make a difference? And we start to talk about presenting at conferences and publishing papers, all very laudable. But how do we actually get this to make a difference for patients? How do we penetrate the health systems and the healthcare systems that we work in to get this to happen? And the answer is we need new science. We need improvement and implementation science. And as clinicians and as laboratory scientists and as people working in the system, we don't get taught this as undergraduates. Not only that, but we've got a healthcare system which is requiring us to do different things. It's requiring us to deliver care closer to home, earlier intervention, fewer acute beds, more standardization, empowered patients at reduced unit cost. So for me, the safest care is the care you don't need. But if you do need care, it has to be high quality and it has to be care that is delivered by people who have the skills to change the system. So within MAHSC, we've been working across all domains, and you've been very permissive of us. We've been quite intrusive. I feel like we're a little virus trying to penetrate the domains. And what we've been doing is been working on a program called Improvement Science for Academics. So this program is tailored towards people who work in clinical care, but also have research portfolios. People from very senior people to entry-level people. And there are people in this audience today that I can see that have been part of this program. But I wanted to share with you, just before we finish, some of the experiences of people on that program.
MAHSC is committed to ensuring that its research benefits patients. Our members deliver high-quality care, but the gap between what we know from research and what we do in clinical practice remains unacceptably wide. In MAHSC, we have taken the bold decision to train our leading academics in the emerging discipline of improvement science. This equips teams with the knowledge and skills required to change healthcare systems for the better. Improvement Science for Academics, or IS4AC, is led by our team at Halo. We bring together teams to work on a healthcare improvement of their choice. Each year, our 6 domain leads put forward teams who will make a bigger difference in the implementation of their priorities.
I think what a fantastic idea to take people who are trained and educated to a really high level and then give them the gift of improvement science.
This year we have teams working on a range of projects, from medication safety to improvements in genetic testing for children with bilateral cataracts.
Over the last 2 years, we've put through almost 20 teams. We have actually been able to look at them coming in with a project and working with people who have expertise in improvement science to actually develop that project into a programme of work that they have then subsequently delivered.
Manchester academics deserve the best, and we use global leaders in improvement science to teach and to coach. One of our teams this year is from a large GP practice called Salford Health Matters.
I'm part of the Access Matters project with the IS4AC, and I'm working with the Salford Health Matters GP practices and Salford CCG to improve access to our GP practices for our patients.
They took on the bold challenge to reduce hospital admissions by 50% by April 2015 and are well on their way to achieving this goal. They are working on a number of significant changes, such as changing the telephony and IT systems, giving receptionists standardised scripts which allow them to take important decisions rather than having patients wait. One of the most important features of their programme is that the way that they have listened to patients throughout and used their voice to inform the changes.
What matters really mostly to me is to be listened to.
Patients who need urgent attention get urgent attention.
The most important thing for me is that a patient who needs to be seen gets seen.
The team have used statistical process control charts to plot their improvement over time. They've learned through case review the reasons why their patients are going to hospital rather than coming into the practice, and are working hard to test innovative solutions. They test changes using the model for improvement, a simple framework which asks them to set an aim, test changes and measure the impact in iterative cycles. Tests are often small scale. One doctor on one day might change the order of their workflow to test its impact on waiting times. If successful, this will be tested again in different settings and ultimately by different doctors, who will feed back to the testing team so that tiny corrections can be made during each testing cycle.
We found the IS4AC project great fun and really useful to be able to learn about how we make improvements to our systems. With the IS4AC programme, we meet regularly with the team, which really helps us focus on what we're trying to achieve. The meetings with our advisors has helped us see the areas that we're weak in and where we can improve our efforts. We were able to realise that we were biting off more than we could chew, and we really needed to focus our efforts and focus our energies on those small changes that are going to have the most impact. And since having done that, we've really seen some gains in what we're trying to achieve.
IS4AC provides important glue for MAHSC. It is one of the only places where academics, NHS professionals and improvement scientists come together from across members and across domains. The standards are high. To graduate, teams need to attend more than 80% of the face-to-face elements of the programme and complete a manuscript which describes their work. If you think you've got what it takes to make a difference, why don't you put yourself forward for next year's programme? For more information, please visit our website.
I just couldn't resist that little punt at the end. We're just recruiting for cohort 3, so there we go. So quickly on innovation, what you see on innovation is that we're trying to think about how we map things differently. I'm just showing you here a screenshot of one of the regions within Salford. This is a piece of work that's been done by colleagues at the University of Salford Think Lab, so Terence Fernando. It's data from across Salford, but they're also working with Manchester City Council. What you're seeing here is data that we've got around populations, which is now being superimposed so that we can see things like where is the crime happening, where are the houses that are empty, and where are the people who are claiming benefits. I'm showing you this because data is a really important part of our domain, and we've got real assets in terms of data analysis and collection. And one of the things that I think you'll see as we emerge into a different future is an opportunity where we'll be able to look at health in a very different way. We'll be able to map things in a very different way. And I wanted to give you a glimpse into the future. So here's a picture of Salford where we can actually start to direct services and direct care and start to support people who are in the greatest need. We couldn't do any of this without our research colleagues, and Ian mentioned that we're connected very closely to the institutes, and the Institute of Population Health, which is headed up by Professor Martin Tickle, who's waving in the audience here, is critical to us. We work closely with them to try to look at how we can do this work better, how we can do evaluation better, but also how we can do large-scale trials in public health and improvement. So I'm going to finish here by saying we have an opportunity in Manchester to rewrite the future. It's here already in part, it's just not evenly distributed, but I think with everybody's help in this room, it can be and it will be. So thank you.
Thanks very much indeed, Maxine. Before you go, I wanted to ask you a couple of questions, actually. Okay. If you don't mind. No, I don't mind. You mentioned the 17-year gap. Yeah. And that strikes me as the key. Great things are happening at the bench, and it just takes too long to get it out to the community. And we can see the work you're doing. Well, I suppose it's understanding systems, isn't it? It's actually how people can navigate their way through. Explain how you make that happen.
Absolutely. So you're absolutely right. So I started my life as a clinician and then did a research degree and suddenly realised that it was fine knowing about how, you improve care for stroke patients, but then trying to actually get into health systems is a completely different science, a different group of skills, which actually we're not trained. So I think there's something about the psychology of change. So why do people resist change? Why do people draw change in? There's something about the systems we work in. So how do things fit together? There's something about understanding variation, so understanding where the bright spots are that you can start to work in, and also understanding the methodologies that you can use to actually get change to happen. And those are not skills that we necessarily have as a community, but there are definite advantages to having them. And when you marry people who have research experience, clinical experience with those skills, you start to see great things happen.
And I guess that's what, MAHSC, in a way, is absolutely about lubricating those routes through, so that anybody, wherever they sit within the wider healthcare and health research community, can say, okay, I'm doing something amazing here. Yeah. I just need to get it out there. I need doctors to know about this stuff.
And so we've had examples in IS4 where we've had people who've developed new genomic tests, not been able to necessarily get them to the patients, gone from 6 years to 6 weeks. Single cases at the moment, but I think the power of this science is really yet to be realised.
Okay, fantastic. Maxine Power, thanks very much indeed. Maxine Power.